This is the 65 years old male, known case of diabetes, hypertension, tobacco cheer, and he presented with the inferior wall ST elevation MI. ST elevation is more in lead 3 than 2, and this is the angiogram. Left system was minor lesion, and this is the RCA with right radial root. This is the RCA. You can see the 99% total, 99% thrombotic occlusion in the mid RCA, and in the next shot I'll show you in the PLVB stenosis. So we started this patient with the right radial root, but you can see the roller coaster, and this is the Lusoria arterio, and you can see how bad it is going catheter. So in such a situation, we could do the angiogram only, but for PTCA, we changed the route to the femoral because of this Lusoria arteriosa. And this is the roller coaster catheter propagation. And the second thing which I want to tell you is, you can see the catheter is exactly during the angio, exactly in the conus artery. So in such a situation, patient may get the VT and all. So what to do in such a situation? If your catheter goes to the conal, just push it down, it will go to RCA. Just gently push it down, just slightly remove it and push it down, it will go to RCA. You can see how big the RCA is. So we started with the procedure. So we changed the route to femoral, and this is you can see the superdominant RCA, how large the PLV and PDA. The above one is the PLVB, posterolateral ventricular branch, and the down one is probably horizontal artery, is called PDA. So this is the near the arrow, this is PLVB branch, and there is a stenosis, significant stenosis, you can see. So we decided to put a one stent here in the PLVB right from the ostium of the PLV, and the second stent in the mid RCA. So after all clearance, we took up the case. So simply with the JR catheter, there was no problem in engaging with the right femoral root. And this is the BMW PTCA wire. Went easily, it was a cakewalk. And at the point of thrombotic occlusion, you can see some sort of aneurysmal lesion. You can notice just above the arrow, there is some sort of aneurysm, or it may be a bend, or some thrombus maybe. So we need to be very careful while putting the wire and all in such a, and while doing stent angioplasty. Aneurysm may get damaged and may perforate. So I wanted to put a distal stent first in the PLVB, but see what happens. I took a stent. It was 2.75 into 24, and I progressed the stent here, and I wanted to take a shot, cine, but this is the thing. And then patient's BP fall down, and so I removed the stent, and I decided to put a proximal stent first, so that we'll get the place. This has happened because of there is no place, and this is a fresh thrombus patient presented after 8 hours of index period. So that is why this has happened. So simply I removed the stent, and the artery was around 3.5, so I removed the stent, and then flow has come, and decided to put a proximal stent first. So this is the 3.5 into 20 stent, and as soon as I place the stent over there, this has happened, flow again has gone. This happens in the ACS. So as early as possible, I deployed the stent, and it was 3.5 into 20 stent. Nominal was 8. I deployed up to a 14, and RVP was 16. So this is the picture after deploying the stent. So probably under deployment, or that aneurysm is there, so, or thrombus, it may be a thrombus. So I inflated same balloon once more, and then it is there, but still it is there. Still somehow it looks good now. And I generally avoid the NC in ACS cases because there is a no flow, reflow, all possibilities are there. So I did not do NC in this patient for this stent. And then second stent we took, it was 2.75 for the PLV, 2.75 into 24. And right from the ostium of the PLV, we deployed the stent. What is the problem in deploying the stent in the distal larger RCA is stent will keep on moving to and forth. So you have to stabilize it either by putting a buddy wire, second wire, or else you have to decrease the heart rate. So we deployed it anyhow. So deployed at around 12 atmospheric pressure. This is the scene after deployment. So there was a TME3 flow. So I took a plain scene to see whether it was aneurysm or any thrombus or any bend of the RCA, and you can notice that there is a bend of RCA. That is why it is looking like that. It looks so you can see clearly in this plain scene, the stent is moving up and down, and now it looks good. Now in this last scene, it is very stable, and that was due to bend only. There was a bend, and because of that bend, we feel that that is the aneurysm or under deployment, but that looks good now. TME3 flow is there. This is a cranial view, and this is the final LAO shoot. You can see how large and super dominant the RCA is. This was a sort of primary angioplasty to the RCA and PLVB. Thank you.